For many of you, lifestyle changes on their own are not enough to bring your high cholesterol down to a healthier level to lower the risk of heart disease. Many of you will need to take cholesterol-lowering medications. So today, I'll be talking about cholesterol-lowering medications and more specifically, how they actually work. Because if you've ever been prescribed a statin or told you might need an injection for cholesterol, it can feel like you're being asked to take something forever for a problem you can't even feel. And yet, lowering certain cholesterol particles is one of the most powerful things we can do to reduce the risk of heart attacks and strokes. So in this video, I'm going to walk you through what these medications do inside your body, why different people end up on different combinations, and how we decide what's enough. I'll keep it practical, and by the end you'll understand why one person does brilliantly on a low-dose tablet, while another person needs multiple tablets and injections, despite both being healthy. If it's your first time here on my channel, welcome. My name is Hafiz, and I'm a cardiologist based in London. I create videos to help keep your heart healthy and explain heart conditions in a way that I hope is easy to understand. If that interests you, then click on the subscribe button and bell icon so you get notified every time I release a video. Okay, let's make cholesterol make sense. The first big idea is this: cholesterol itself isn't the villain. Cholesterol is a normal building block. Your body uses it for cell membranes, hormones, vitamin D, bile acids, so it's needed for normal, healthy function of your body. The issue is how cholesterol is transported around the body, because cholesterol doesn't dissolve in blood. It has to be carried in little transport particles called lipoproteins. The one we talk about most is LDL, low density lipoprotein, often nicknamed bad cholesterol. LDL particles carry cholesterol from the liver out to the tissues. When there are too many LDL particles circulating for too long, some of them get into the lining of the artery wall. Over time, that drives inflammation and plaque buildup, what we call atherosclerosis. Plaque can gradually narrow arteries, but the really dangerous moment is when plaque becomes unstable and ruptures, triggering a clot that blocks blood flow, causing a heart attack if it's the coronary arteries, or a stroke if it's in the brain. So when we say lower cholesterol, what we mainly mean is lower LDL related risk. We're trying to reduce the number of LDL particles in the bloodstream because fewer particles generally means fewer opportunities for plaque to build and destabilize. And here's the second big idea. Your liver is the control center. Your liver makes cholesterol, packages it, and crucially clears LDL particles back out of the blood using LDL receptors, which you can think of as little docking stations on liver cells that pull LDL out of the circulation and recycle the cholesterol. Many cholesterol medications, even though they sound different, are basically clever ways of getting your liver to remove more LDL from your blood. Now, before we jump into the medications, we need to talk about how we decide who needs what. In the UK, the NICE guidelines emphasizes that treatment decisions should be based on overall cardiovascular risk, not just one number on a page. For people without established cardiovascular disease, NICE recommends using the QRIS-3 tool for adults and prioritizing people for a full formal risk assessment when their estimated 10-year risk is 10% or more. For primary prevention, where you don't have established cardiovascular disease, NICE recommends aiming for more than a 40% reduction in non-HDL cholesterol when using statin therapy. If you already have cardiovascular disease, so you've had a heart attack, a stroke, symptomatic vascular disease, or documented coronary disease, then we call that secondary prevention, and the targets are tighter because the risk is higher. NICE recommends aiming for LDL cholesterol of 2 millimoles per litre or less, or non-HDL cholesterol of 2.6 millimoles per litre or less in secondary prevention. And it also explicitly says don't delay statin treatment for secondary prevention while you work on lifestyle. Do both in parallel. In specialist lipid clinics, targets can be even lower for very high-risk people. We often aim more aggressively in people with coronary artery disease. For LDL below 1.4 millimoles per litre in coronary artery disease, reflecting very high-risk practice where the goal is to push risk as low as is reasonably achievable. Okay, so what do the medications actually do? Let's start with the backbone, statins. Statins work mainly by slowing the liver's cholesterol production. They inhibit an enzyme called HMG-CoA reductase, which is a key step in forming cholesterol. When the liver can't make as much cholesterol internally, it compensates in a very helpful way. It increases LDL receptor activity so it can pull more LDL out of the bloodstream to meet its needs. That's why statins lower LDL in the blood, less production plus more clearance. Statins are widely used to lower cholesterol and they can reduce LDL by around 30%, sometimes even 50% with high doses. A lot of cholesterol, especially LDL driving cholesterol, is made in the liver regardless of how perfectly you eat. Diet matters, absolutely, but for many people, lifestyle changes alone won't bring LDL down enough to meaningfully lower risk, particularly if there's a genetic component. That's why you can meet someone who runs marathons and eats well and still has high LDL. It's not a moral failing, it's just physiology. Let's talk about the statin conversation that almost always comes next, side effects. The most common side effect is myopathy or muscle pain. In real clinical practice, we take symptoms seriously. We don't dismiss people, and we also don't assume every ache is caused by the statin. We will usually do baseline blood tests and a clinical assessment, including things like a full lipid profile, diabetes status, renal function, liver function, and thyroid function if there are symptoms suggesting thyroid disease. Then after starting or changing lipid-lowering treatment, we will check liver function and a full lipid profile at around 3 months, checking liver function again at 12 months and not repeating routinely after that unless clinically indicated. On muscle symptoms specifically, we would advise to seek medical advice if you develop unexplained muscle symptoms, and if that happens, we measure creatine kinase. If CK is less than 5 times the upper limit of normal, we would reassure that the symptoms are unlikely to be due to the statin and look for other causes. If we think it is caused by the statin, then we can do a couple of things. We can try a different statin, as your body may respond to it differently, or we can stop it altogether. To get the most of your statin, take it every day to keep your cholesterol levels down. I would advise to take it at the same time every day. Your doctor might suggest you take your statin at night before you go to bed. That's because the liver is more active in making cholesterol at night. This is except for atorvastatin and rosuvastatin, which you can take at any time. If you forget to take your statin, carry on as normal the next day. Don't take an extra one to make up for it. Avoid grapefruit juice if you're taking simvastatin, and no more than 1 or 2 small glasses of grapefruit juice if you're taking atorvastatin. If you're struggling with your statins, for example, if you're having side effects, don't simply stop them because your cholesterol will go back up. There's usually a very simple solution, such as trying a different statin or a lower dose. Now, what if a statin helps, but it's not enough? Or what if someone can't tolerate a useful dose? This is where people often assume the only option is keep increasing the statin forever, but there are other options. The next medication to know about is Ezetimibe, and Ezetimibe works in a completely different place, the gut. Ezetimibe is a cholesterol absorption inhibitor. It partially blocks the cholesterol absorption in the small intestine, so less cholesterol gets into your bloodstream from food and from bile that your body recycles. Then, because less cholesterol is arriving at the liver from the gut, the liver responds by pulling more cholesterol out of the blood, again using LDL receptors. Here's the practical reason ezetimibe is so useful. Adding a second mechanism often gives you a bigger LDL drop than simply doubling a statin dose, with fewer side effects than trying to push one drug to the maximum. Increasing atorvastatin from 40 mg to 80 mg gives an additional LDL reduction of around 8%, whereas adding ezetimibe to atorvastatin 40 mg can give nearly 20 to 25% additional reduction. That's a brilliant example of why combination therapy is so common in lipid clinics. It's not escalation for the sake of it, it's using two levers, liver production and gut absorption, with the shared end result of improving LDL clearance. Like all medicines, ezetimibe can sometimes cause side effects. If you take it by itself, it can cause abdominal pain and problems with digestion. If you take it with a statin, it can cause muscle pain and raise liver enzymes. Importantly, ezetimibe is not suitable during pregnancy or if you're breastfeeding. Now, sometimes we meet people who genuinely can't tolerate statins, even after trying different ones. And yes, trying different statins matters. In specialist practice, we often encourage trying at least 2 different statins before deciding someone is truly statin intolerant, because people can react differently to different options and different dosing patterns. If statins aren't suitable, you still have options. One of the newer oral medications is bempedoic acid, which comes in a tablet. Bempedoic acid targets cholesterol production in the liver, but at a different step in the pathway than statins. It inhibits the enzyme ATP citrate lyase, which reduces cholesterol synthesis and helps lower LDL. It inhibits cholesterol synthesis in the liver, and it can be used as a combination tablet alongside ezetimibe. In clinical trials, bempedoic acid has been shown to reduce LDL cholesterol by between 17 to 28% after 12 weeks. When combined with ezetimibe, bempedoic acid can give up to 38% reduction in LDL cholesterol. There's also a practical side effect point that's worth mentioning because it's so easy to miss. Bempedoic acid can increase uric acid and increase the risk of gout, so we often check uric acid before starting it. So far we've talked tablets. Now let's talk about injectables, because this is where cholesterol treatment starts to feel high-tech, and it can sound scary until you understand the target. The key player here is PCSK9. PCSK9 is a protein made by the liver that reduces the number of LDL receptors available on liver cells by promoting receptor breakdown. If you have fewer LDL receptors, you clear less LDL from the bloodstream and LDL levels rise. The PCSK9 protein breaks down LDL receptors. PCSK9 inhibitors stop that protein from working, and that means more LDL receptors and lower cholesterol. There are 2 main clinical ways we target PCSK9. The first is with PCSK9 monoclonal antibodies like alirocumab and evolocumab. These are injections usually given every 2 to 4 weeks. They bind to PCSK9 and stop it from doing its receptor-destroying job, so LDL receptors can keep recycling and clearing LDL out of the blood. The second option is inclisiran. Inclisiran doesn't just block PCSK9 after it's made, it reduces how much PCSK9 the liver produces in the first place. It's a small interfering RNA, known as siRNA, which basically interrupts the printing of PCSK9 from its genetic message, so the liver makes less PCSK9 protein, LDL receptors can recycle, and LDL clearance improves. So rather than catching the bad guy every time it appears, you're turning down the factory that keeps producing it. Because it works at the production level, inclisiran lasts much longer in effect, which is why the dosing schedule is so different. The standard schedule is 1 injection, then another at 3 months, and then every 6 months thereafter. Now, who is eligible for these injectables? The answer is they're reserved for people at high risk or people who haven't achieved targets on maximally tolerated oral therapy. And there are specific criteria tied to national guidance and local pathways. In England, inclisiran is available as a secondary prevention option for people with known cardiovascular disease when LDL remains at or above 2.6 millimoles per litre, despite the maximum dose of other lipid-lowering treatments. Specialist pathways also use thresholds and repetition rules to make sure we're treating persistent levels, not one-off blips. In coronary disease contexts, as considering inclisiran, when LDL remains above 2.6 millimoles per litre, and PCSK9 inhibitors when LDL remains above 3.5 millimoles per litre, with the practical point that you need at least two values above the threshold. In familial hypercholesterolemia, PCSK9 inhibitors are considered when LDL is above 5 millimoles per litre. Statins have decades of evidence showing they reduce heart attacks and strokes. PCSK9 monoclonal antibodies also have outcomes evidence. Inclisiran definitely lowers LDL substantially, but long-term event reduction evidence is still being gathered. There is currently no long-term evidence showing whether inclisiran prevents events such as heart attacks and strokes, and it notes ongoing trials expected to report in the coming years. That doesn't mean inclisiran doesn't work. It means it works very well at lowering LDL, and we're waiting for the long-term outcomes data in the same way every new therapy has to earn its place over time. We also don't combine inclisiran with a PCSK9 monoclonal antibody. They both target PCSK9, so there's no extra benefit in stacking them, so they should not be given together. Now, up to this point, I've been talking like LDL is the whole story. It's a huge part of the story, but not the entire story. Some people have a mixed picture. LDL may be reasonable, but triglycerides are high, or LDL is controlled, but risk remains high. Triglycerides are another type of fat in the blood, often linked with insulin resistance, diabetes risk, alcohol, genetics, and overall metabolic health. Fibrates are medications known as peroxisome proliferator activated receptor agonists, and they regulate various steps in fat metabolism. Their main effect is on reducing triglycerides and have been shown to lower triglycerides by 50%, lower LDL cholesterol by up to 20%, and raise HDL by up to 20%. Fibrates are prescribed by a lipid specialist and are used alongside statins to help lower triglyceride levels. Fibrates are not routinely offered to prevent cardiovascular disease, and omega-3 supplements do not have evidence for preventing cardiovascular disease except for a specific prescription omega-3 product called icosapent ethyl in a specific group of people. This is not official from the supermarket. It's a prescription form of EPA that in clinical trials reduce cardiovascular events in people with established cardiovascular disease who are already on statins with well-controlled LDL but who had raised triglycerides. Raised triglycerides are a marker of risk, and clinical trials show icosapent ethyl can help lower the risk of heart attacks and strokes in people with known cardiovascular disease whose LDL is controlled on statins but who have raised triglycerides. Omega-3 compounds aren't used for prevention except icosapent ethyl, in line with its technology appraisal guidance. Practically, what does this mean? It means if someone has had a heart attack, is on a statin, has LDL under good control but fasting triglycerides remain raised, icosapent ethyl can be part of the conversation in the right context. It is not a replacement for statins, and it's not the new cholesterol drug everyone should take. It's a specific tool for residual risk in a specific group. While we're on practicalities, let's talk about blood tests and why some people get told to repeat them. A full lipid profile includes total cholesterol, HDL, triglycerides, and then LDL is often calculated along with non-HDL. A fasting sample is not mandated for a lipid profile, but LDL results may not be reported when triglycerides are high, depending on the calculation method used by the lab. That's one of the reasons we sometimes request fasting samples or repeat tests when triglycerides are very elevated, because the LDL number might not be reliable or might not appear at all. I've done a detailed video explaining your cholesterol blood test, so check it out after you've watched this video. It will help make sense of your blood test. In specialist services, we also sometimes use alternative equations when triglycerides make LDL difficult to calculate. But for most people, the main point is, if your doctor repeats your lipids, it's usually not because they didn't believe the first test, it's because they want the most meaningful numbers to guide the next step. Now let's zoom in on the stepwise approach, because this is where people either feel reassured or feel like they're on an endless treadmill of medication. Think of it like this. The first step is always understanding the risk context. Are we preventing the first event or preventing another event? That changes targets and urgency. NICE guidance anchors primary prevention around QRIS-3 and a goal of more than 40% reduction in non-HDL with statin therapy, whereas secondary prevention uses explicit LDL and non-HDL targets and says don't delay treatment. The next step is choosing a statin dose and intensity that makes sense and the person can tolerate. NICE defines high-intensity statins as doses expected to produce larger LDL reductions, including atorvastatin 20 to 80 milligrams and rosuvastatin 10 to 40 milligrams. That doesn't mean everyone must be on the maximum dose. It means we aim for an effective intensity and we tailor it to interactions, side effect risk, kidney function, frailty, and patient preference. And then we check response. NICE recommends checking liver transaminases and a full lipid profile at around 3 months after starting or changing lipid-lowering therapy. And that's the moment where you and your clinician can look at the trajectory and decide whether you're on track for targets. If targets aren't met, the next step shouldn't be panic and it shouldn't be blame. If the lipid target isn't met, discuss adherence and timing of the statin dose and encourage ongoing lifestyle changes. In real life, a surprising amount of statin failure is actually inconsistency, missed doses because of shift work, uncertainty about when to take it, stopping it during an unrelated illness, and forgetting to restart, or quietly halving the dose because of fear. A calm, non-judgmental conversation fixes a lot. If adherence and tolerability are good and LDL is still above target, that's when add-on therapy comes in. We will add other lipid-lowering treatments in secondary prevention when targets are not met on the maximum tolerated statin, including Ezetimibe, inclisiran, and PCSK9 inhibitors, and consider Ezetimibe in addition to the maximum tolerated statin to reduce risk further, even if the lipid target is met in appropriate secondary prevention contexts. If statins aren't tolerated, Ezetimibe is an option, or bempedoic acid with Ezetimibe when Ezetimibe alone doesn't control LDL well enough in statin-intolerant people. Let me also talk briefly about genetics because it affects how early and how aggressively we treat. Familial hypercholesterolemia, known as FH, is a genetic condition where LDL is high from birth, meaning arteries are exposed to high LDL for decades. NICE recommends using clinical findings, a full lipid profile, and family history to judge the likelihood of a familial lipid disorder rather than strict cutoffs alone. And it recommends specialist assessment for very high cholesterol levels, even if there's no known family history. In specialist lipid services, FH assessment and genetic testing pathways exist because identifying FH doesn't just help the patient, it helps family members through cascade testing and early prevention. And then there's lipoprotein little a, or LPA, which you'll increasingly hear about. Lp(a) is an inherited risk factor for atherosclerotic cardiovascular disease that isn't captured by a standard cholesterol panel unless it's specifically tested. In specialist practice, we test it in certain contexts: family history of premature cardiovascular disease, familial hypercholesterolemia, and a few other scenarios. There are no pharmaceutical agents that specifically target Lp(a), although treatments are expected in the future, which is one reason some clinics follow patients with higher levels rather than discharging. I've done a whole video explaining Lp(a) in detail, so check it out later. There are also other medications that may be used, such as bile acid sequestrants that target bile acids and can lower cholesterol by 18 to 25%. There is also advanced treatments like LDL Apharesis, which is a treatment that removes the cholesterol from the blood. It works similar to dialysis, as your blood is passed through a machine which filters out the cholesterol and is returned to your body. This is used for a small number of people with very high cholesterol levels, which can't be brought down by medications and diet. The treatment can lower your LDL cholesterol and Lp(a) by 60 to 75%, making a big difference to your cholesterol levels. They do rise again quite quickly, which is why you need to have treatment every 1 or 2 weeks. It's usually used for people with high cholesterol that's caused by their genes, such as familial hypercholesterolemia. So to summarize, cholesterol-lowering medication is not one single ladder where you either need it or you don't. It's a toolbox. Statins reduce cholesterol production and increase LDL clearance. Ezetimibe reduces gut absorption and complements statins. Bempedoic acid is another liver-targeted option that's useful when statins aren't tolerated, often combined with ezetimibe, with a watch out for gout risk. PCSK9 therapies supercharge LDL clearance by protecting LDL receptors, either by blocking PCSK9 with antibodies every couple of weeks, or by reducing PCSK9 production with inclisiran every 6 months after the loading dose. And in the right high-risk patients with raised triglycerides despite statins, icosapent ethyl can reduce event risk, but it's a specific tool, not a general supplement. And finally, if you need cholesterol-lowering medication, it doesn't mean you failed. It doesn't mean you ate badly or you're destined for a heart attack. It means your risk calculation and your biology suggests you'll benefit from reducing LDL exposure over time. For some people, that's a single tablet. For others, it's a combination. The goal is not perfection. The goal is risk reduction. Quiet, steady, over years, so that the heart attack that might have happened simply never happens. Let me know in the comments below if you lowered your cholesterol and what helped you. Thanks so much for watching. If you found this explanation helpful, please give the video a thumbs up, subscribe for more cardiology insights, and share it with someone who might benefit. See you next time.